Hello, today I will be discussing VBAC, Vaginal Birth After Cesarean Section. VBAC refer to a planned attempt to deliver vaginally in a woman who has had a previous cesarean delivery. It is an important topic in modern obstetrics because it offers women an opportunity to experience vaginal birth while also helping to reduce the rising global cesarean section rate. With proper case selection, careful monitoring, and appropriate facilities, VBAC can be safe and successful option for many women. In this presentation, we will explore its definition, eligibility criteria, benefits, risk, and management. Now, I will discuss the antenatal visit schedule during pregnancy. Antenatal care is structured and systemic follow-up of a pregnant woman to ensure maternal and fetal well-being, early detection of complications, and timely intervention. In the first trimester, the first visit should occur before or at 12 weeks of gestation. This visit is very important for detailed history taking, general and obstetric examination, baseline investigation, dating ultrasound, and risk assessment. During the second trimester, visits are usually scheduled at around 20, 26, and 30 weeks. At each visit, blood pressure, weight, fundal height, fetal heart rate, and urine testing are assessed. Screening for anemia, gestational diabetes, and anomaly scan are also done during this period. In the third trimester, visit become more frequent, typically at 34, 36, 38, and 40 weeks. The focus is on monitoring fetal growth, detecting hypertensive disorder, assessing fetal movements, and planning mode of delivery. High-risk pregnancies require more frequent visits and specialized care. Thus, a well-structured antenatal schedule plays a crucial role in reducing maternal and perinatal morbidity and the mortality. Now, I will discuss which women are suitable candidates for vaginal birth after cesarean or VBAC. Proper patient selection is the key factor for successful and safe VBAC. A woman is considered suitable if she has had one previous lower segment cesarean section with a transverse uterine incision. This type of scar has the lowest risk of uterine rupture. She should have no history of previous uterine rupture and no other uterine surgeries such as classical cesarean section or extensive myomectomy. The current pregnancy should be a singleton with cephalic presentation, and there should be no contraindication to vaginal delivery such as placenta previa or obstructed labor. Adequate pelvis, clinically spontaneous onset of labor, and availability of continuous fetal monitoring also increase the success rate. Most importantly, the facility must have the capability for emergency cesarean section if required. With careful counseling, informed consent, and proper monitoring, VBAC can be safe and appropriate option for selected women. Now I will discuss the contraindication of vaginal birth after cesarean section or VBAC. VBAC is not recommended in certain situations where the risk of uterine rupture or maternal and the fetal complication is significantly increased. The most important absolute contraindication is a previous classical cesarean section where the uterine incision was made vertically in the upper segment. This type of scar has a higher risk of rupture during labor. Similarly, a history of previous uterine rupture is a strong contraindication for attempting VBAC. Women who have undergone extensive uterine surgery such as a deep myomectomy entering the uterine cavity are also not suitable candidates. In addition, any contraindication to vaginal delivery in the current pregnancy, such as placenta previa, transverse fetal lie, or cephalopelvic disproportion, automatically contraindicate VBAC. Relative contraindication may include multiple previous cesarean section, short interpregnancy interval, suspected macrosomia, or the need for induction with certain agents. Therefore, careful assessment and individualized counseling are essential before planning a trial of labor after cesarean. Now, I will discuss the possibility of VBAC after two or more previous cesarean sections. Traditionally, women with multiple previous cesarean deliveries were advised to undergo repeat elective cesarean section due to the increased risk of uterine rupture. However, recent evidence suggests that carefully selected women with two previous lower segment transverse cesarean section may still be considered for a trial of labor. The main concern in such case is the increased risk of uterine rupture compared to women with only one previous cesarean. Therefore, thorough counseling regarding potential risk and benefits is essential. VBAC after two cesarean may be considered if the woman has previous lower segment transverse scar, no history of uterine rupture, no other uterine surgery, singleton pregnancy with cephalic presentation, no contraindication to vaginal delivery. Most importantly, the delivery must take place in a well-equipped center with continuous fetal monitoring and immediate access to emergency cesarean section and blood transfusion facilities. VBAC after 3 or more cesarean section is generally not recommended due to significantly higher risk. Therefore, individualized risk assessment, informed consent, and strict intrapartum monitoring are the key principles in managing such cases. Now I will discuss antenatal counseling for vaginal birth after cesarean or VBAC. Antenatal counseling is a crucial step in planning a safe and successful trial of labor after cesarean. Counseling should ideally begin early in pregnancy and continue throughout antenatal visits. First, we assess the type of previous cesarean scar, indication for previous surgery, number of prior cesarean, and any history of uterine rupture or complication. The woman should be informed about the benefit of VBAC, including shorter hospital stay, faster recovery, lower risk of surgical complications, and reduced risk in future pregnancies compared to repeat cesarean section. At the same time, she must be counseled regarding the risk, particularly uterine rupture, which though rare, can have serious maternal and the fetal consequences. The possibility of emergency cesarean section should also be discussed. Success rate of VBAC, which are generally around 60 to 80% in appropriately selected women, should be explained to help realistic decision making. The importance of delivering in a well-equipped facility with continuous fetal monitoring and immediate surgical backup must be emphasized. Finally, shared decision making and informed written consent are essential part of antenatal counseling. Thus, proper counseling ensures that the woman understands both benefit and risk, allowing her to make an informed and confident choice regarding her mode of delivery. Now I will compare vaginal birth after cesarean or VBAC with elective repeat cesarean section. VBAC refer to a planned trial of labor in a woman with a previous cesarean delivery, whereas elective repeat cesarean section is a planned surgical delivery before the onset of labor. In terms of benefits, VBAC offers shorter hospital stay, faster recovery, less blood loss, lower risk of surgical complication, and fewer adhesions. It also reduces complications in future pregnancies such as placenta accreta and the placenta previa. On the other hand, elective repeat cesarean section avoids the risk of uterine rupture and eliminate the possibility of emergency cesarean during labor. It provides a plain and the predictable timing of delivery. However, elective repeat cesarean section is associated with operative risks such as infection, hemorrhage, anesthesia complication, thromboembolism, and increased risk of abnormal placentation in future pregnancies. The major concern with VBAC is uterine rupture, although the risk is low in properly selected women. There is also a chance of failed trial of labor requiring emergency cesarean section, which carries higher morbidity than a planned cesarean. Therefore, both options have advantages and risks. The decision should be individualized based on clinical factors, patient preference, previous obstetric history, and availability of emergency facilities. Proper antenatal counseling and shared decision making are essential in choosing the safest mode of delivery. Now let's discuss the success rate and factor influencing vaginal birth after cesarean or VBAC. Overall, VBAC has a success rate of about 70% in appropriately selected women. This means that roughly 7 out of 10 women attempting a trial of labor after cesarean will deliver vaginally. The success rate increased significantly in women with a previous history of vaginal birth, reaching 80 to 90%. The highest success is seen in women who have had a prior successful VBAC. Other factors also influence success. Younger maternal age and normal body mass index are associated with higher success, while advanced age and obesity reduce it. The indication for the previous cesarean is important. Non-recurring indication like fetal distress or malpresentation favor success, whereas a previous cesarean for cephalopelvic disproportion lower the chance. Gestational age and fetal size matter too. Post-term pregnancy or suspected macrosomia can reduce success, while a singleton with cephalic presentation improve outcome. Labor-related factors play a key role. Spontaneous onset of labor, a favorable Bishop score, and adequate pelvis increase the likelihood of successful VBAC. Induction of labor, especially with prostaglandin, may reduce success and slightly increase risk. Finally, a longer inter-pregnancy interval improve outcome, while a very short interval may pose additional risk. In summary, success depends on a combination of maternal history, obstetric factor, fetal characteristics, and labor condition, which should all be considered during counseling and planning. Planned VBAC at 39 weeks of gestation. Now I will discuss plain vaginal birth after cesarean or VBAC at 39 weeks of gestation. A plain vaginal birth after cesarean is usually scheduled around 39 weeks in women with a previous lower segment cesarean section and no contraindication to vaginal delivery. This timing balances the benefits of fetal maturity with minimizing the risk of spontaneous labor before hospital admission. Before planning labor, thorough antenatal assessment is essential, including confirmation of fetal well-being, estimated fetal weight, presentation, and assessment of maternal pelvic adequacy. Spontaneous onset of labor is preferred. Induction or augmentation should be used cautiously as it slightly increases the risk of uterine rupture. Continuous fetal monitoring is recommended during labor. Women should deliver in a well-equipped facility with immediate access to emergency cesarean section and blood transfusion services. Counseling regarding the risk, benefits, and success probability should be reinforced during these visits, and written informed consent should be obtained. With proper selection, monitoring, and timely intervention, plain VBAC at 39 weeks is safe and effective approach for many women. Intrapartum care for VBAC. Now I will discuss intrapartum care for vaginal birth after cesarean or VBAC. Intrapartum management is critical to ensure maternal and the fetal safety during a trial of labor after cesarean. First, continuous maternal and the fetal monitoring is essential. This includes regular assessment of vital signs, uterine contraction, and continuous fetal heart rate monitoring to detect early signs of distress or uterine rupture. Labor should start spontaneously. If induction or augmentation is required, oxytocin may be used cautiously, while prostaglandin are generally avoided due to higher risk of uterine rupture. Progress of labor should be closely observed using WHO labor guide and regular cervical examination. Any abnormal labor pattern such as prolonged labor or failure to progress should prompt timely evaluation and consideration for the emergency cesarean section. Pain management should be individualized. Epidural analgesia is safe and does not increase the risk of uterine rupture and can help the woman tolerate labor better. Prepare for emergency intervention is mandatory. The operating theatre should be immediately available and the team should be ready for urgent cesarean or management of complications such as hemorrhage or the scar adhesions. Finally, supportive care, reassurance, and continuous communication with the patient are important to maintain confidence and cooperation throughout the labor process. Proper intrapartum care maximizes the chance of a safe and successful VBAC while minimizing maternal and the fetal risk. Labor and induction for VBAC. Now I will discuss labor and induction in women attempting vaginal birth after cesarean or VBAC. Spontaneous onset of labor is preferred in VBAC as it is associated with higher success rate and lower risk of uterine rupture. Continuous monitoring of maternal vital signs, contractions, and the fetal heart rate is essential throughout the labor. Induction of labor should be approached with caution. Oxytocin can be used carefully to augment labor if the cervix is favorable, but the dose should be low and gradually increase under close monitoring. Mechanical methods such as Foley catheter may also be used for cervical ripening safely. Pharmacological agents like prostaglandin, particularly misoprostol, are generally avoided because they significantly increase the risk of uterine rupture in women with previous cesarean section. Labor progress should be regularly assessed using a WHO labor care guide, and any sign of abnormal labor, fetal distress, or uterine scar complication should prompt immediate evaluation and possible emergency cesarean. Pain relief, including epidural analgesia, is safe and recommended to help the woman cope with labor. Ultimately, the goal is to support safe vaginal delivery while minimizing risk with readiness for prompt surgical intervention if necessary. VBAC in special circumstances. Now I will discuss vaginal birth after cesarean or VBAC in special circumstances. Certain situations require useful consideration, individualized assessment, and specialized monitoring when planning a VBAC. VBAC may be considered in women with 2 previous low transfer cesarean if there are no other contraindications but the risk of uterine rupture is higher. VBAC after 3 or more cesarean is generally not recommended. Previous classical or vertical uterine incision history, then VBAC is contraindicated due to very high risk of uterine rupture. Pregnancy with fetal macrosomia, VBAC can be attempted cautiously, but suspected large babies increase risk of labor dystocia and failed VBAC. Short interpregnancy interval, women with less than 18 months between pregnancy may have increased risk of uterine rupture, so VBAC should be carefully considered. Twin pregnancies, VBAC can be attempted if the first twin is cephalic and there are no other contraindications, but continuous monitoring is essential. Women with previous uterine surgery, extensive myomectomy or uterine reconstruction increase risk, and VBAC is generally not recommended. In all special circumstances, VBAC should only be undertaken in a facility with immediate access to emergency cesarean section, continuous fetal monitoring, and a skilled multidisciplinary team. Proper counseling, individualized risk assessment, and shared decision making are essential to maximize safety and improve outcomes. Elective Repeat Cesarean Section, usually scheduled at 39 weeks, and care pathway include preoperative, intraoperative, and postoperative care. Preoperative care include counseling, consent, investigation, anesthesia review. Intraoperative care include prophylactic antibiotic, spinal anesthesia, safe surgical technique. Postoperative care include monitoring, pain control, early mobilization, and wound care. This table from the guideline showing risk and benefits of opting for VBAC versus elective repeat cesarean section from 39 weeks of gestation. Plain VBAC 72 to 75% chance of successful VBAC if occur, then shorter hospital stay and recovery. Approximately 0.5% risk of uterine scar rupture if occur, associated with maternal morbidity and the fetal morbidity and the mortality. In other hand, elective repeat cesarean section from 39 weeks able to plan a non-delivery date in selected patients. This may, however, change based on circumstances surrounding maternal and the fetal well-being in the antenatal period. Usually, avoid the risk of uterine rupture and longer recovery, reduce the risk of pelvic organ prolapse and urinary incontinence in comparison with number of vaginal births, at least in the short term. Option for sterilization if fertility is no longer desired. Evidence suggests that the regret rate is higher and that the failure rate from sterilization associated with pregnancy may be higher than that from an interval procedure. If sterilization is to be performed at the same time as cesarean delivery, counseling and arrangement should have been given at least 2 weeks prior to the procedure. In plain VBAC, increased likelihood of future vaginal birth, risk of anal sphincter injury in women undergoing VBAC is 5%, and birth weight is the strongest predictor of this. The rate of instrumental delivery is also increased up to 39%. Risk of maternal death with plain VBAC of 4/1 leg. In other hand, in elective repeat cesarean section, future pregnancies likely to require cesarean delivery, increased risk of placenta previa, accreta, and adhesions with successive cesarean deliveries and abdominal surgery. Risk of maternal death with elective repeat cesarean section of 13/1 leg. Infant outcome in plain VBAC, risk of transient respiratory morbidity of 2 to 3%. 10 per 10,000 prospective risk of antepartum stillbirth beyond 39 weeks while awaiting spontaneous labor. 8 per 10,000 risk of hypoxic ischemic encephalopathy. 4 per 10,000 risk of delivery related perinatal death. This is comparable to the risk for nulliparous women in labor. In other hand, infant outcome in elective repeat cesarean section, the risk of transient respiratory morbidity of 4 to 5%, 6% risk of if delivery performed at 38 instead of 39 weeks. The risk is reduced with antenatal corticosteroid, but there are concerns about potential long-term adverse effect. Less than 1 per 10,000 risk of delivery related perinatal death or hypoxic ischemic encephalopathy. Definitions of term plain VBAC. Plain VBAC refer to the intended mode of delivery of any woman who has experienced a prior caesarean birth who plan to deliver vaginally rather than by elective repeat cesarean section. Successful and unsuccessful plain VBAC. A vaginal delivery in a woman undergoing plain VBAC indicate a successful vaginal birth after cesarean. Delivery by emergency cesarean during the labor indicate an unsuccessful VBAC. Uterine rupture. Disruption of the uterine muscle extending to and involving the uterine serosa or disruption of the uterine muscle with extension to the bladder and broad ligament. Uterine dehiscence. Disruption of the uterine muscle with intact uterine serosa. Perinatal mortality. Combined number of stillbirth, antepartum and intrapartum, and neonatal death between 20 weeks of gestation and 28 days of life per 10,000 live birth and stillbirth. Perinatal mortality rate will exclude death due to fetal malformation unless otherwise stated. Term delivery related perinatal death. Term delivery related perinatal death is defined as the combined number of intrapartum stillbirth and neonatal death per 10,000 live birth and stillbirth 8 or beyond 37 weeks of gestation. Birth related perinatal mortality rate exclude antepartum stillbirth and death due to fetal malformation unless otherwise stated. Neonatal respiratory morbidity. Combined rate of transient tachypnea of the newborn and respiratory distress syndrome. Example of a schedule of antenatal care. First visit at 12 weeks. Provision of written patient information on delivery option, VBAC and elective repeat cesarean section. Second visit 18 to 21 week. Ultrasonographer to perform mid-trimester scan for fetal anomaly and placental localization. Reschedule ultrasound at 32-34 weeks for women identified to have a low-lying placenta with a history of previous caesarean delivery. Then 21 to 28 weeks antenatal counseling appointment for women with uncomplicated singleton pregnancy and single previous lower segment caesarean delivery. Document counseling of risk and benefits of VBAC versus elective repeat cesarean section. A review of the previous caesarean delivery with access to the woman's previous obstetric medical record should take place. Counseling should be undertaken by a member of the maternity team. Midwifery review for all pregnant women. Undertake routine review and completion of 28-week screening test. Full blood count, AB or ACS D group status. Administration of anti-D if appropriate. Then at 32 to 34 weeks visit, obstetrician lead assessment of women with previous caesarean delivery who are identified to have a low-lying placenta at 32 to 34 weeks obstetric ultrasound. The aim to provide adequate time for investigations and management of possible placenta accreta. Midwifery review for women with normally seated placenta, establish women's preference for plain VBAC or elective repeat cesarean section, and ensure suitability for plain VBAC. Then visit at 36 weeks, obstetrician-led assessment to determine mode of delivery for women who opt for elective repeat cesarean section, are undecided on mode of delivery, or have complicated obstetric and medical disorder like multiple pregnancy, delivery of a macrosomic infant, birth weight more than 4 kg, small for gestational age, or fetal growth restriction, pre-eclampsia. Midwifery review to confirm suitability and maternal preference for plain VBAC. A woman understands all risk benefits, has normally grown fetus with cephalic presentation, no other obstetric complication. Then after 39 weeks, performing a elective repeat cesarean section. If elective repeat cesarean section is required prior to 39 weeks for obstetric or medical indication, then prophylactic antenatal corticosteroid may be considered to reduce the risk of neonatal respiratory morbidity like transient tachypnea of the newborn, respiratory distress syndrome. However, concern regarding the long-term safety should be discussed with mother. Then at 41 weeks, senior obstetrician-led assessment for women who had opted for plain VBAC but have not gone into spontaneous labor. Risk and benefit of various options are discussed and documented. Options include membrane sweetening, prostaglandin, amniotomy, or polycatheter, indication of labor, elective repeat cesarean section, or expectant management. Clinical management of pregnant women who have had one or more cesarean birth. Any contraindication to VBAC, placental localization, exclude previa or accreta, review previous record and operative notes, medical or obstetric conditions that preclude VBAC, antenatal counseling, and shared decision-making process. Explain risk and benefits of plain VBAC versus elective repeat cesarean section, including the individualized likelihood of VBAC success. For example, women with previous vaginal birth should be informed that previous vaginal delivery, particularly previous VBAC, is the single best predictor of successful VBAC and is associated with plain VBAC success rate of 85 to 90%. Greater maternal height, maternal age less than 40 years, BMI less than 30, gestation of less than 40 weeks, and infant birth weight less than 4 kg are associated with an increased likelihood of successful VBAC. In addition, spontaneous onset of labor, vertex presentation, fetal head engagement or lower station, and higher admission Bishop score also increase the likelihood of successful VBAC. Successful VBAC is more likely among women with prior cesarean for fetal male presentation, 84%. Elicit choice for mode of delivery and how it fits with future reproductive preference. Intrapartum care for VBAC, delivery setting, monitoring analgesia, recognizing failure to progress or uterine rupture. Caution if induction and or augmentation are considered necessary. Intrapartum care for elective repeat cesarean section, preferred gestational timing to conduct cesarean from 39 weeks. Perioperative management of women in special circumstances. VBAC is the presence of high-risk obstetric factor. In conclusion, vaginal birth after cesarean is a safe and effective option for carefully selected women. Thank you all for your time and attention. to conclude, vaginal birth after cesarean remain an important and safe approach when patients are carefully selected and appropriately monitored. Through proper counseling, individualized assessment, and well planned intrapartum care, we can optimize outcome for both mother and baby. I truly appreciate your listening and I welcome any question or discussion.